So, good morning, good afternoon, good evening, and welcome everyone to the Global Café. My name is Katrina Brazanis. I'm the Director of Policy and Advocacy here at the IFA. And so today we'll be taking a deeper look at maintaining function in later life and the intersection of rehabilitation and mobility and promoting healthy aging. So mobility is central to overall health and well-being, and it is crucial to healthy aging as it allows older adults to maintain their independence, engage in social and community life, access necessary resources, and ensure good physical and mental health. And many older adults experience declines in mobility, yet there's rarely a discussion surrounding assessment and prioritizing prevention to avoid injury and loss of independence. So Professor Marla Beauchamp is here today to speak about this and also many other facets of her research. So Marla Beauchamp is a physical therapist, an associate professor in the School of Rehabilitation Sciences, and an associate member in the Department of Medicine at McMaster University. She is also the inaugural associate scientific director of the McMaster Institute for Research on Aging. Dr. Beauchamp holds a Tier 2 Canada Research Chair on Mobility, Aging, and Chronic Disease, and an Early Researcher Award from the Ministry of Colleges and Universities focusing on mobility and technology. So the overarching aim of Dr. Beauchamp's research is to identify ways to keep older adults mobile and healthy and in their homes and communities for as long as possible. So welcome, Professor Beauchamp.
Thanks very much, Katrina. It's nice to be here. And good morning, everyone.
Thank you very much for being here and joining the Global Cafe. So at the Global Cafe, it's always nice to go back to the beginning and learn a little bit more about yourself and what first interested you in studying firstly physical therapy, but then how did you become more interested in older people and specifically rehabilitation and mobility?
Well, I think I've always I was incredibly close to both my grandparents, my grandmothers in particular. And I think that in general interested me in working with older adults from a very young age in my career. Um, Physical therapy, it was sort of, I was just, I had finished my undergrad in biology and math, and I was sort of trying to think, well, what's next? And we had worked as a medical writer for a while, and had worked even as a personal support worker, and I was sort of it just struck me as a profession where it would be, to be trained as a healthcare professional, number one, in a climate where that would always be needed. And then the idea that I remember seeing a video clip on the news of a physical therapist teaching someone to walk again after a stroke. And it sort of occurred to me that, I mean, what could be more rewarding than that? So I went and did my master's in physical therapy, and my favorite placements and internships were in the different various kinds of geriatric units, and then I also loved research, and so that's why I ended up going on to do my PhD and postdoc.
Mhm. So, speaking of that love of research, you have many different ongoing research projects, and many of them are quite, overarching, very interdisciplinary. So I'm wondering if you can tell us a little bit more about the focus of your research, some of the overarching things that connect all of these different projects that you're doing, and also kind of how that came to be the area of research that you wanted to work in.
Well, I think my background in physical therapy certainly made me realize right away how important mobility was. So my entire research program, the common theme and it is a bit, might seem broader, but the common theme is how do we increase people's mobility as they age, and how do we keep people living independently and mobile in their homes and communities for as long as possible. So everything is centered around that. Um, I sort of I'm interested in sort of two different areas of research underneath that theme. And one is, how can we better assess people's mobility as they get older and intervene earlier? So how do we identify problems at the very earliest possible stage and intervene when we can have the most impact? And then the second part is then how can we, what kinds of management strategies and intervention work can we do to help people who are already living with mobility problems or who are just at the start of having mobility issues? How can we prevent a lot of the consequences that occur with that? I'm sorry, my dog has heard something. Um, and, uh, so that's sort of the second piece of it. Uh, and then within that, there's so many different chronic disease populations that have um, that have mobility problems, and it really is. We often refer to it as the sixth vital sign because it's just so important to as we age, and it predicts a number of different health problems, and so. Um, this is why a lot of my research is focused on, for example, people with chronic obstructive pulmonary disease, and why I've started studying COVID-19 because mobility issues are common across a lot of these different disease populations.
Mhm. So you mentioned, that sixth vital sign idea, and I'm wondering if you can explain a little bit more about what that means in terms of mobility as a sixth vital sign and why is it so critical to maintaining good health and I think I can imagine that there's such a high burden of decreased mobility in older people. So I'm wondering if you can share a little bit more about that.
Mhm. So, first of all, when we talk about mobility, what we mean by that is, people's ability to move around in their environment, to walk, to climb stairs, but also to, use transportation and to do the activities that they value. And so what we found is if we study how people move and what their mobility ability looks like, it can predict a number of things like whether or not you'll fall, have a hospitalization, um, uh, develop disability, be institutionalized. It's an incredibly strong predictor of all these health outcomes. And a vital sign is essentially it's a reproducible measurement of the basic functioning of a living being. And if we think of things like blood pressure, that we commonly measure, well, actually, how someone moves is a pretty basic thing also. And when people come into the hospital, it's one of the first things, or they come in even into the emerge, it's one of the first things we assess in the healthcare system. In addition to those other sort of more common vital signs, we do look at how someone's moving. It becomes part of our clinical judgment. Yet we're not sort of explicitly doing this all the time as people get older. And so this idea of mobility as a vital sign is, how can we make this a part of routine care? So it's something that we're routinely monitoring, assessing, and then intervening on because likely if we did this, we could have the biggest impact on people's healthy aging. And if we think of even the new definition of healthy aging, it's by the World Health Organization, it's defined as the process of enabling and maintaining the functional ability that people need to maintain and do the things that they value. And mobility is inextricably, it's a huge part of that. It's incredibly linked to that. And so it's really this essential component of how we age. And so, if we think about uh, when people, if you've had children, you go to the doctor's office and you often you get a growth chart, right? Of how your child, what is their weight, what is their height, what is their percentile, and imagine we did this for mobility as people were aging. This could be a really great way to help prevent a lot of the known consequences of mobility problems that sort of underlie a number of different chronic conditions. And so if we, again, if we go back to that example of blood pressure as a vital sign, I would argue that mobility is probably even a more comprehensive and holistic marker of someone's health than blood pressure, which might be more related to one particular system.
Mhm. Yeah, thank you for that response. And yeah, it's true that mobility is so kind of truly linked to all of the things that, a person would want to do, in their daily lives. So I'm wondering if you can talk a little bit more about how exactly we measure and assess mobility in older persons, and also, where does it currently sit in terms of when people kind of are going in for their primary care checkups and things like that, do we look at mobility currently? And, I'm wondering if you can share what is kind of the status of assessment, and what do we need to do to improve that?
Right. So, currently it would depend on, what context you were seeing, in primary care, there's often not a lot of time for mobility assessments. It would depend on the family physician whether or not they would ask you uh, questions about your mobility. We can assess it a number of different ways. It would, self-report. We can simply ask, "How is your mobility? How do you walk? How do you climb stairs?" And there are standardized instruments, and so like questionnaires that we can use to measure this. And then there's performance-based measures, which and those tend to be used more. Maybe some physicians would do this in primary care, but usually it would be physical therapy, allied health, if you were being seen in a falls clinic or for rehabilitation, for example, that they would use these kinds of tests. But you could look at someone's gait speed, for example. So just timing them over a few meters walking and seeing what their sort of usual gait speed is. Tests like the ability to get out of a chair, walk a few meters, turn around, come back and sit down. That's called the timed up and go. That's pretty common. Balance tests like the ability to stand on one leg. How, are you able to stand on one leg? How many seconds can you stand on one leg? Those are sort of the common ways that mobility is assessed in our current in the current healthcare system. What has been gaining more and more attention, the issue with these types of assessments, right, is we're asking people, well, what can you do? And we're asking people, we're looking and watching people move and looking at what, how they're moving in a particular standardized setting on a test, but it doesn't actually tell you what people are doing in their daily lives. And so that's what we've referred to in this new framework that we've worked on as, actual mobility. So there's perceived mobility, and then there's, which is, asking people about their mobility. There's their capacity for mobility, which is these sort of performance-based tests like that walking speed or balance, for example. And then there's actual mobility, what people do in their daily lives. And we can get at that by asking questions about how often you move, how often you leave the house, for example. But there's a whole movement in using wearable technology. Like we do have the technologies now where we can actually measure people's mobility within their homes and in their communities. And if we do that properly and integrate that as part of our health assessments and part of a wider sort of central healthcare strategy as people get older, then we can really understand, well, how often is this person, for example, leaving the house, and how might that relate to health outcomes, and what kind of, beyond, and there's also new technologies beyond what, if we think of wearable technology like smartwatches, we often think of things like step count, for example, or physical activity, but mobility is a lot broader than that. And with some of these tools, we can look at we can look at how, again, like I was saying, how often someone leaves their house, what's the maximum distance they go from home, the complexity of people's movements within their communities, and that can give us sort of a more holistic idea of how someone's moving within their environment, and maybe a more personalized way that we could give prescribe or give people advice on how to move and how to be healthier as they get older. And so that's a big part of my research program, and a lot of different initiatives around the world are focusing on this sort of real world mobility assessment and how we can use technology to do that, and ideally do it in a non-obtrusive way, with very low burden, highly usable technology, because we certainly understand that technology is not for everybody.
Mhm. Yeah, I think it's really, really interesting, that kind of idea of, that real world evidence of what people are actually doing in their day. And it's everybody has like a Fitbit or like a smartphone or things
Right.
like that that can, that capacity to map that is really there. So I'm wondering, you know, what have you seen from your research? Can you share anything that you're finding so far?
Well, just quickly to say about these Fitbits and devices like that, the only issue with those devices, and they can be great and they can be motivating for people, um, is that they weren't often developed or validated for older people. So it means that they may not capture all the steps that an older person takes. And some of their, like, built-in algorithms for, when they make or predictions or any kind of output that would be offered may not necessarily apply to someone who is older, who has some mobility problems, or maybe uses a walker or a rollator to walk. Right? Because then, if you're wearing it on your wrist and you're stationary, then these kinds of devices don't always capture um, all the movement that an older person with these kinds of mobility issues would do in a day. So I think it's really important to remember that, and I think we do need a lot in terms of technology development that is done within sort of a health within the health sciences sphere, and that are really done for healthy aging, for the purpose of promoting healthy aging, and done in older people. And I'm sorry, now I'm forgetting the second part of your question, Katrina.
No, I really appreciate you kind of adding that caveat, because obviously this is, something that older people are often left out of kind of research and development in terms of tools like this or technology like this. And so I appreciate you adding that detail. But the second part of the question was really what your findings have shown you so far.
Oh, right. So we've been doing this large mobility monitoring study called MAC-M3, or McMaster Monitoring My Mobility. And it's been quite exciting. We have sort of 1,200 older people enrolled, and we've customized technology that can measure, like what we were just talking about, that has GPS and accelerometry, so we can actually measure how often people leave their home, what are their life space areas, um, also how often they're active, and more traditional things like step count. And what we're seeing is that those kinds of measures map really well onto sort of our more traditional assessments that we've been using in clinic. They do distinguish between people that are having say that they're having no difficulty with moving, versus people that are having sort of early, what we call preclinical mobility issues. So these are um, times when someone will say, no, I don't have difficulty walking, or I don't have difficulty doing any of my mobility tasks, but I've modified the way that I do them, or I do notice I get tired more often. Um, And that's a harder distinction. The traditional tests that we have, like the walking, like just walking in a straight line and measuring speed, can't often tell us a lot about these preclinical issues, these really early signs. And what we're finding is with doing these actual mobility monitoring in people's daily lives, it's a lot more sensitive to detecting these kinds of earlier mobility or preclinical mobility problems, the problems before they actually become a disability for people. Um, and then the other thing is that they seem to identify people that have fallen, people that go to the emergency room, people that have hospitalizations. So they are really sensitive markers of these things, and they do characterize people that end up or the people that report more of these issues. Now, we haven't finished our cohort, so I can't comment definitively on some of this yet. This is our preliminary data looking mostly at our baseline data so this is data from people from the I think we're close to 1,200 people. So looking at the 1,200 people that have done our assessment at baseline, they've come in for an in-person visit, and we've done a sort of a comprehensive health assessment on them and measured their mobility in real life over sort of a 10-day period. Um, and so we're looking at this over 2 years now, and what we're hoping to do with this research is then to be able to say, okay, these are the most sensitive of all these different things we can measure, like step count, like life space area, like frequency of trips outside the home, which ones are the most sensitive to falls, to hospitalizations, to institutionalization, to development of mobility, other mobility problems, which ones are the most important, and then what are sort of meaningful thresholds on these things. So what is it that we really, we've all heard of the 10,000 steps that became very popular, but actually was not really based in evidence at the beginning. There is some evidence now, but that's not necessarily the most sensitive threshold for and not for old, and again, not necessarily for older people. So how can we develop these thresholds so we can give people really good advice on how they're moving and how much they need to move and what is the most important things? Because maybe it's not really about how many steps you take. Maybe how complex or rich or large your life space area is, or how often you leave the home, that might actually be even more important and more sensitive, and maybe an easier thing to modify for people as they get older. So that's one of the things we're hoping to do in our research. And there's certainly other research out there that has shown even these more traditional metrics like step count and like bouts of physical activity and how sedentary someone is during the day. Those are incredibly strong predictors of a number of different outcomes, including mortality as we get older. And even just in older adults of their general health. Um, and so, we know that the value of these kinds of markers is really potentially outstanding. So how can we validate these for older people and get this information in the hands of older people in the health and social systems that are around them, so that we can use this information to improve people's experience of aging?
Mhm. Yeah, I think that's a really interesting question, is kind of what that threshold is and what are the actual things, because you're right, there's a lot, I think, in the media and
Mm.
just, on social media, on the internet about,
Yeah.
these kind of trendy things, I would say,
Yes.
about health. So yeah, it'll be really interesting to learn, I think, what are the true markers in an evidence-based way, and specifically
Right.
older people. So I want to go to the chat
Mhm.
ask a few questions to you from the chat that revolve more around how do we kind of incentivize these things in terms of government, and what the role of government is, and what the role of these things are in our kind of health and social care systems. So there's a question from Shmuel, who is a weekly contributor at the Global Café, and he's asking, what is the role of governments in developing kind of effective rehabilitation systems for older adults in specifically in kind of low socioeconomic groups of the population? But then there's also another question from Jane who's asking, what will press the government to kind of invest in this area? So I want to kind of smush those two together a little bit.
Yeah. So great questions, not easy questions,
Yeah.
to
Never an
answer.
easy question on the Global from the Global Cafe
No,
audience, so
no. I would argue that this is, I mean, and it's so important, and I wish that there was more investment in rehabilitation and in preventative strategies. And I'm in Canada, so I can speak to that context more easily. But I know around the globe, there's a call for a lot of our systems are built very reactively, right? So you won't get in, you won't have access to rehab or physical therapist, or allied health, or, unless you have a fall or unless you've had a hip replacement. And so people get into the system, and have access to these rehabilitation services typically only after there's been a health event. And I do think we need to shift from that sort of reactive focus to a more preventative model of care. And unfortunately, and we have incredible pressures with our aging of the population. It's honestly the first time in history that we've had um, the number of people as living as long as people are living, but also living more years often in poor health. And so how can we really do need to increase people's functional ability as they get older. Otherwise, we're not going to have the health and social systems to be able to support the number of people that will be aging with mobility problems. Um, and so how do we do this? I think, I think it's a unfortunately, it's about advocacy in our communities for these kinds of services and programs. And we're certainly trying in rehabilitation sciences to do this, but I think what is needed is for rehab and mobility to become part of central health strategies. And I have a colleague that often talks about this, like how can we um, integrate function and people's mobility as part of the system. And again, this is where I think some innovation is going to be needed, in interdisciplinary work, where we get people that have expertise in different, because to do this properly, we need the right data, we need the right probably technology, because I think, people, the time is so limited, for example, in primary care right now, that there is no time to do these assessments. So how do we sort of shift the burden away, do these assessments maybe remotely, and have that information come back then when you go see your family doctor, or you go, how do we put this in the community so that maybe you can walk into a library or your pharmacy and maybe rent a device or borrow a device and get some information back that's actionable that you can use to help manage your health and then bring to your healthcare professionals. So how can we do that? How can we, and I think to do that, we do need, we need people that have the expertise. Like we need engineers, we need data scientists, we need rehab professionals, we need doctors, we need all these people to come around the table and problem solve and actually integrate this. So it's an investment in how we implement these kinds of things, because we have the knowledge, we know how important mobility is, we know how important rehabilitation is and access to rehabilitation, and it's one of the, it's actually a very cheap way to keep people healthy. compared to medicines and pharmacological intervention. And so, how can we increase access to rehabilitation for people and to these strategies to maintain functional ability? And I think that if we have the right people around the table, we can answer these kinds of questions, but it will take a focus on how do we actually implement this, and how, and making sure that we get the right people with lots of diverse expertise around the table to do this kind of work.
Mhm. Yeah, and I think you're right in that it does require a sort of reorientation of the way that, many health systems are designed, which is, as you said, reactive as opposed to preventative. And it really does require some of that kind of investment in prevention and understanding that that will kind of reap certain benefits in the long term. Um,
Right. And it's a hard thing to show to governments because it's not the when there's a health problem and you fix it, there's an immediate payoff, right? Whereas prevention takes a longer time to show. And so I think it's a harder sell, and we learned that with the pandemic, right? In a way. And so I think that we do need to, it needs to be a mindset shift. And I think as researchers, we also need to study more of the health, like beyond the health outcomes, what is the cost effectiveness of a lot of the approaches that we use. Let's show, so that we have the data to be able to advocate, to say, you know what, these kinds of approaches, this kind access to these kinds of services, this focus on prevention actually makes a difference and saves money down the line, because that's ultimately what puts you in the best position to be able to advocate. And maybe we don't do as good of a job at that.
mhm. Yeah, yeah, absolutely. I think that that's a really, really great point, and something that you see over and over again. At the end of the day, a lot of times it's about kind of a bottom line, and showing that these are things that, by decreasing hospitalizations and decreasing the need for all of these more kind of intrusive interventions, you are kind of reducing health system burden.
Yeah.
So I want to, shift gears a little bit and ask about COVID-19, because much of your work has looked at how COVID-19 affects function and mobility. So I'm wondering if you can talk a little bit about that sort of aspect of your research.
Sure. And I mean, that's more recent. And it was, um, I felt very, very fortunate to be in the field that I am in, to be able to, when the pandemic started, to start to study this. And I did my PhD in pulmonary rehabilitation. So that's rehabilitation for people living with chronic lung disease. And so that's one of the reasons why I became interested in COVID-19. And a lot of the physicians that I was working with wanted us to wanted to know how we could capture information on hospitalizations, on how people were recovering from the illness. And so we started a few projects to look at this. So we looked at it in a few different ways. We looked at it just within our community cohorts. We had to stop a lot of our research during COVID because they couldn't come to in-person assessments, and so we did a telesurvey with, like, using a random number list. This was called the impact study, and we did this during the pandemic, and we looked at people's mobility just during the pandemic, like people just living in the community, and what was happening to people, because the messaging was very much stay inside, and reduce your activities. And so that did have consequences. People did report reduced levels of physical activity, and they reported more mobility problems. This is just in general, without even taking into account illness. And then we studied with these physicians, and respirologists and internal medicine physicians. We started a project called Courage, which was about looking at, we were prospectively at anyone that was hospitalized in Hamilton, this is in a region in Canada, in Hamilton, Ontario, and in Kitchener-Waterloo. So we had 5 different hospitals, and anyone that was hospitalized with a confirmed COVID-19 infection, we captured all their information about their hospitalization and blood markers and symptoms on admission, and then we actually then consented consecutive people that came in, and asked them if they would be willing to be in a follow-up study, and then we followed them for a year, actually 2 years. We've just finished our 2-year assessment, but I don't have the data from that yet, but I have the 1-year data. And if we followed people every 3 months for 1 year, and they were so kind to let us do that. And what we found is that, people's recovery, especially after serious COVID, was really not complete. So following people every 3 months for 1 year, we still saw at 1 year that between 40 to 50% of people that had been hospitalized for COVID-19 still had mobility levels, mobility ability. They were still reporting uh, clinically, what we would consider to be clinically important deficits in their mobility. So these were really meaningful problems in people's ability to move. And this was in 40 to 50% of people over 1 year of hospitalization. And then we also saw deficits in people's cognition. So they were also reporting, when we looked at applied cognition, they were also reporting deficits in their cognition, and that was about 40% of people over 1 year. And then we looked at a number, and we had self-report data. We went to people's homes and did home visits and measured a bunch of these things more objectively, as they say. And no matter which way we measured it, we were seeing these kinds of deficits. And in our cohort, and this was almost 300 people, hardly any of them had had any access to rehabilitation. And so there were people 1 year out from COVID that still hadn't regained their full level of functioning. And we also, so that was a hospitalized based cohort, but then we thought, well, what's happening? What about people that got COVID in the community and older people that got COVID in the community? How did they recover? And so we were able to leverage the Canadian longitudinal study on aging, which is a large population-based study in Canada that includes 50,000 older people. And so we had, the nice thing about the Canadian longitudinal study on aging is you have data on how people were doing before, right? And you also have this sort of built-in comparator group because you're following everybody. And so the CLSA launched a COVID survey during the pandemic, and we were able to look at people's mobility when they had an infection, and then look at the background level of people that didn't have an infection. And in this sample, most people were not hospitalized, and we still saw that COVID was impacting people's mobility and their function, and so this is people that didn't have serious illness for the most part, people that were living in the community that had this respiratory virus. And it's probably not that dissimilar from maybe other viruses that people have as they get older. But people, again, were not recovering to the same, were not getting fully back to where they were before. And they were having sort of new onset of difficulty doing some basic mobility tasks. And this is really, I think, really significant. And I don't think we've fully seen the impact of COVID, the disease itself, the pandemic on aging. And I think we'll probably see that in the years to come.
Mhm. Yeah, I think it's so interesting because it does make you really reconceptualize, what the true burden of COVID is, because it's not just the kind of acute infection and things like that. It really is, from all the data that you've just shared, it really is, really long term impact on functioning. And I think this certainly goes back to what we were talking about when you're kind of making the advocacy case, which is really important to have all of that information and that full picture to then say to governments, this is the prevention of diseases like this other kind of, I think about pneumonia and influenza that would probably
Yeah.
be similar, is actually really important because the burden is so large in the long term.
Absolutely. And it's not new information because, I mean, if people that have chronic lung disease, for example, people that are living with emphysema or chronic bronchitis, they have these acute flare-ups, what we call acute exacerbations. And we know that after they have these flare-ups of their disease or after they become sick with respiratory viruses, they do have a lot of mobility problems. They do often need rehabilitation. So this is not um, it's not new, and it's something we need to do better at is having the systems ready to support people after they become ill, to regain what they've lost.
Mhm. So I have a couple of follow-up questions just based on what you shared, which is one is there's another question in the chat from Ishmael who's asked how healthy aging and rehabilitation can support prevention and development of dementia. And you mentioned that there was you also saw cognitive kind of losses of in cognitive function with COVID-19. So I'm wondering if you can respond to that question and also share a little bit more about kind of the losses in cognitive function and how that plays into this.
Right. So I can't say for sure that in the follow-up, like the COVID follow-up study, we measured cognition and we measured mobility, and we did this sort of concurrently. And so I can't say that one led to the other. But we certainly know that being active and being mobile is, if we that is part of a strategy to to try and reduce the impact of dementia. And so I think they certainly are linked. We know they're linked. And so being mobile, and it might be, and again, this is one of the things we're measuring in the studies that we're doing is, maybe some of those other markers, the non-traditional, like beyond physical activity, beyond step count, this idea of how often people leave the home and maybe where they go and who they interact with, maybe that kind of information is better linked to cognition, right? That gives us, because that's community mobility is particularly important for promoting social interactions, and for reducing social isolation. And we know the kinds of the effects that has, are enormous.
Mhm.
And so if I think mobility underpins all of that, is one of the underpinning factors. And so, strategies to increase people's mobility are likely to have impacts on cognitive impairment and dementia. And there are people, this is not, I'm not an expert in dementia or cognitive impairment, but there are people that are studying this. And certainly mobility is incredibly important uh, for maintaining our mental and social well-being as we get older.
Yeah, absolutely. And then I just want to go again back to the chat. There's a question from Cynthia. Cynthia, would you like to unmute and pose your question?
Sure. Well, thank you for being here today. Wow, it's very fascinating. But I was just thinking, I just read an article about the difference that women versus men have with falls, and some of the projections for cause for women, the estrogen levels post-menopause. But I just wondered, in your own practice, whether you see, differences between men and women in the prevalence their ability for balance and also falls, because talk about an area that can cost benefit analysis. If you can keep people mobility or balance and prevent falls, you already save a lot of money.
Oh,
So
you're
I'm wondering, from your perspective as a clinician.
Cynthia, that's a fabulous question, and a very active also area of research. And fall prevention is really important, and also very close to my heart too. It's one of my favorite things to study. Um, and I think I'm interested in studying it because I fall very regularly. I'm a very clumsy person, and I can't even imagine certainly the impacts of that as we get older. And I've certainly seen it in my practice, and I've seen it in my research. And so yes, so women, there are sex and gender differences in falls. And we see that the issue with that research, we've actually just completed a review on that, where we've sort of looked at a whole body of literature and tried to understand, what actually the research was showing. And consistently across the literature, there was either a sex or gender difference reported in all kinds of things, and the factors that increase risk for falls, and the prevalence of falls, and injury from a fall. And so there were common sex or gender differences reported. What was really difficult about looking at all of that research is that sometimes people would report gender, and sometimes people would report sex, and they would do that interchangeably. So it was a little bit hard to tease out
Mhm.
what was what, but we certainly see um, uh, so it's hard to say if it's biology or if it's social, and it's probably a combination of the two. So I think, um, women do have some biological differences, or people that are of female sex have some biological differences in terms of maybe their muscle strength and things like that as they get older, that might predispose them to having poorer balance, um, and having a higher risk of falls. But there's also these social, the kinds of activities
Mhm.
that women and men undertake can be different, right? And so
Mhm.
sometimes
Mhm.
men have higher risk, take do some higher risk activities than women, and women might um, have different ways of being active. Um, and the thing is, women also live longer. So when you live longer, you have more opportunities to fall too, right? So it's a really complex issue, and and the other thing that I find too is, um, if I think about my practice, women tend to be there, again, and not to generalize, but again, in the literature, we also see this. They're more likely to come for a health assessment, to report their falls, to try and get help. And so that's one difference that I do see. So even in my research, it's harder for us to recruit men. And that's something we found in our studies. We actually have a lot of the studies have a lot more women in them, and we don't actually have as much information from men. And so that's also contributing to it. So it's really hard to say, is there a difference? Yes, in almost everything that we looked at, there was a difference. But why that difference exists is not that easy to say. And I think that's there's a World Falls Guideline initiative that is led by Manuel Montero Dasso at Western University, and I'm part of that. And my role on that is actually to lead a sex and gender working group where we look at some of those things. And so we are starting to tease that out and trying to figure out what are the recommendations. Maybe do the recommendations need to be different depending on your sex and gender? And so it's a fabulous question, but not a straightforward answer. So thank you for that.
Yeah, thanks, Cynthia, for that question. Yeah, I mean, so interesting, the different things that go into that potential difference. And, I think talk about kind of going back to the need for older people to be involved in research, but also the need for, to have that both genders of older people,
Mhm.
so you can really kind of tease out those differences. So, and the kind of
Yeah.
the wide variety of older people that exist within that research cohort.
Yes, and I think someone had said before, now I just realized I didn't touch on it, but you know, in terms of people that are um, what we historically unrepresented are older people, but also people that are marginalized, right? So we don't have a lot of information on people that have, the people that volunteer for research tend to be more educated, tend to have higher levels of income. And so we don't have information from these structurally marginalized groups and how they're aging. And what we do know is that they have even more, they have lower levels of health literacy, lower or health, and a higher prevalence of mobility problems. So this is a particularly high risk group of people that have really been left out of most of the existing research. So a lot of the research that we're talking is from a very privileged group. So we're probably really underestimating the extent of the problem. And we need to think of approaches that can actually reach some of these people that might need it the most.
Mhm. Yeah, it's a great point. I mean, it just goes back to not truly kind of understanding that burden, because you would only imagine that those groups have even higher, um, issues with mobility or, falls or whatever that may be, just given what we know about social determinants of health and things like that.
Absolutely.
So I do want to go to we're coming very close to the end of the session, but I want to try and sneak in just a couple of more questions. So there's a question from Emily. Emily, would you like to unmute and pose your question? If not, I'll maybe pose it. But it just says, as a clinician, what are kind of your rehabilitation interventions or recommendations to address preclinical mobility limitations for middle-aged adults?
Mhm. And I saw Emily did manage to just unmute and then,
Oh, sorry. Sorry
but
about
it's
that. Emily,
okay.
did you wanna
Yeah, yeah. So I'm very interested in understanding about this preclinical mobility limitations because I found that I'm actually a person living with young onset dementia, and
Mhm.
I found there is some kind of when I see my peers, there is this no, there is this link, of course, cannot be proven, of course. Yeah, that about mobility, the lack of the ability to do the functional thing has
Mhm.
do with their dementia, the progress of the dementia. So when you mention about the preclinical thing, that
Mhm.
I'm very interested in how when we talk about prevention of dementia, we are trying to target not those. I mean, the healthy people will be the one who will be doing all the, but it's the one that you said in the center, not in the gray zone.
Yeah.
They know that they are going to have it because they are still have that cognition to come in with intervention to help themselves to
Yeah.
change the thing, but then they are at the risk. And
Yeah.
also, how do we? I mean, based on your experience as a clinician, are there recommendations for people at the middle age?
Mhm.
Yeah,
Yeah, that's a great
I
question. Great question, Emily. And I think this is also again an area that we need more work in because we again, even our research is often focused on people once they already have mobility problems, and we don't do a good job at identifying people very early on. But I would argue, and many others would argue, that this is actually the optimal time when we start to notice changes in how we move. That is the time where our impact of any kind of intervention that we do will be the greatest. We don't have a lot of research on people with preclinical mobility issues, but um, some of the research that we do have, and I know some of my colleagues are doing work in this area too, is that this at this point we want to do mobility interventions that are sort of that have that have a component of sort of speed and thinking and dual tasking, right? So we want to look at programs that, maybe like that incorporate dance, like that have some sort of movement that you have to also engage and think about how you're moving and move to a beat. When I worked clinically, I did a lot of what we call dual tasking. So having people, if we were doing balance work, I would ask them, okay, let name every word you can think of that starts with a J, and do this and balance at the same time, right? So how do we engage our minds and our cognitive, like how do we tax both systems at the same time, right? And so I think that kind of work is certainly being done and is incredibly important. And I think that those kinds of programs are really important for people that are having preclinical mobility problems or problems with and are concerned about dementia and cognitive ability. I think working on both systems at once are going to be really important. And so we do need more research on that. And there are people doing it, but I think there's a lot that can be done if you're at that stage, and joining any kind of program, something that interests you or that you feel, because it has to be something that you want to do. Not everyone wants to do a dance program, or not everyone wants to do Tai Chi, or, but these kinds of, if you could figure out something that interests you to do, like that's available in your community, I think it would be fabulous.
Thank you, Dr.
Yeah.
I will be thinking on that because I'm supporting my peers who are living with dementia also. Yeah, so we
Yeah.
try ways of how to slow down because a lot of my peers are going down, you know, at the speed that we are thinking of.
Yeah.
Probably can not be so fast, but somehow they're declining very fast, especially for
Right. Right.
yeah.
And just, and honestly, I often tell like a lot of patients is sometimes even just just going out and getting to that program, even if you can't participate fully or do everything, just getting out and getting there and those social interactions that you have, and just getting to wherever that place is really important. And that in and of itself is a success. So it doesn't have to be that you can do every part of it, but just getting out and accessing these kinds of programs and just being out, literally getting out of the house and getting there, is an important part of maintaining our health. And having social interactions and building networks and all of those things have an impact. And so it's not just about the actual program itself, or the actual exercise or mobility or rehab that you're doing, but it's all of the things that come with it that are also really important.
Thank you so much.
Thanks so much. So we are just about at the end of the session. So there's lots of questions, and I'm sure we could go on for much longer. I am just going to take a minute just to introduce next week's speaker, and then Dr. Beauchamp, I'll come back to you just for your final thoughts on our conversation. So, Berenice, did you want to share the screen? Oh, perfect. There we go. So our speaker next week will be Dr. Adrian Berg, who will be speaking on, let me just pull it up. I don't know why it's not showing up for me, Berenice, but I'll let everyone know what next week's is. So it'll be ageism in tourism and why the hospitality industry ignores the mature traveler. So it should be an interesting session next week, and hope everyone will join us for that. And then Professor Beauchamp, I'll just go back to you for any final takeaways. There we go. Everybody can see the tile now. Thank you, Berenice. Yeah, Professor Beauchamp, any final thoughts that you would like to kind of leave us with before we end the session?
I guess it kind of I think goes back to Emily's question. I think the final takeaway would be think about mobility holistically. I think we need to think about it beyond just physical activity and step count, and ways that you can increase your mobility because you have direct control over it. It's something that it is a vital sign. So if there's any takeaway, it's how important this is. And if exercise is not your thing, then just getting out of the house, being active in the community, moving in any way, shape, or form that brings you purpose is really, really important. And so I guess that would be my major takeaway. And certainly if there is an opportunity ever to advocate for this idea that we need to have, we need more access to rehab. We need to focus more on prevention. And we need these strategies now because people are aging now and we're not set up to deal with the numbers of people that are going to be aging and that are going to have mobility issues and functional problems as they get older. So move and advocate and move in any way that moves you.
Thank you so much. A great note to end on and a wonderful conversation. So, as I said, there were so many questions that we could have asked. I'm sure we could have kept going, but thank you so much, Professor Beauchamp, for being with us on the Global Cafe. And thank you to everyone who participated, as well as to the IFA staff that helped to make our Global Cafes happen every single week. And we'll hope to see you all next Friday.